Bioethics Grand Rounds is brought to you by the Center for Bioethics and Social Sciences in Medicine. I'm really excited about today's talk because shared decision-making is sort of the gold standard when we think about decision-making for our patients and kind of upholding the highest ethical standard. And it involves eliciting preferences from our patients. And patients who have severe developmental disabilities or cognitive impediments, it's challenging. And so there's no better person I can think of to talk to us about this than Sara Mohideen, who is a Michigan lifer. She grew up in Michigan, went to Michigan undergrad, went here to medical school, stayed here for her psychiatry residency, and then also did child and adolescent psychiatry fellowship here. And then, of course, they brought her on staff, and she's been here since that time. She's the director of the Multidisciplinary Autism Clinic, and I really look forward to her remarks.
Thank you, Dr. Virkler. When Dr. Virkler was talking to me about presenting today, I was discussing with him some cases that I've had recently where many of these issues have come up, particularly around thinking about adults with developmental disabilities, how to think about consent or engagement with procedures or with medical professionals, as well as kind of moving beyond that into thinking about their quality of life, housing preferences, preferences for guardianship versus various levels of autonomy and involvement around decision making. And we thought it would be good to kind of share some of those thoughts with you. So my hope today is kind of to cover a little bit of background and then to go into talking about some cases. So I don't have any disclosures that are relevant to this talk. So I'm going to talk a little bit about the prevalence of developmental disabilities. I think it's important for all of us to understand kind of how common these are, how often maybe we're missing them or not thinking about it, and then thinking about how historical issues play a role in what we think today around decision making for individuals with developmental disabilities. And then looking in a little bit more depth at the American Association for Intellectual and Developmental Disabilities position statement on these issues. They have a fairly well thought out framework for it. And then I'm going to present another alternative framework that has been presented in the field of developmental disabilities, and then go into talking about some more challenging cases that I've run across in thinking about autonomy and decision making. When I think about developmental disabilities, as somebody who kind of specializes downstream in autism spectrum disorders, but sees a wide range of developmental disabilities, we know that there are a number of different networks that track the prevalence of developmental disabilities in the United States. So one of those is the CDC that tracks both developmental disabilities and autism rates. And what you see is that the rates of developmental disabilities are rising slightly, but have remained in the same ballpark for the last 10 or so years. And that's about 15% of children between 3 and 17. So that's about 1 in 6 children. So what disorders they're kind of grouping into this framework are individuals with intellectual disability or cognitive impairment, but also individuals with hearing impairment, vision impairment, cerebral palsy, other motor impairments, and autism spectrum disorder. So there's a wide range that kind of falls within that framework. And it's important to really think about that range because it does impact the way we think about autonomy and decision making when we think about the wide spectrum that exists within developmental disabilities. And I'll talk about that in a little bit more detail as well. And so I also wanted to include this infographic around the increase in prevalence with autism spectrum disorders. So I know that this does get a lot of press in terms of the rising prevalence, but it's really important to think about because as of right now, as we think about the rising rates, the majority of the field of autism for the last several decades has really been geared towards thinking about infants, early childhood, early intervention, and school age years. And there really has been a huge increase in our understanding and thought process around what it means for these individuals as they transition into adulthood and what it means for them later in life. and how these issues interplay around autonomy and decision making. And so some recent data that has come out in thinking about what these kids look like long term, because we actually don't have a lot of information about what they look like over time, is that in particular, individuals with ASD have lower rates of participation in employment in comparison, and highest rates of no participation compared with youth in all other disability categories. So there's something in particular that's happening with these individuals with autism that is impeding their forward progress, particularly in terms of employment. And why is this employment indicator really important? Because we know across various categories of developmental disability that employment and rates of employment are actually tied with rates of guardianship and autonomy around decision making. And this has been shown across a number of different disorders. So this idea that these individuals with autism are having lower rates of employment leads us to believe that they may be at higher risk for kind of moving into full guardianship or guardianship categories beyond what we would expect for their overall level of functioning. And how does this tie in with what we know around the prevalence of autism? For many years, we used to think of autism as being closely tied with intellectual disability. And looking at the more recent CDC data, what you see is that actually about half of individuals with autism spectrum disorder do not fall within the cognitively impaired range. So this older idea that these individuals require kind of higher needs services and go on to have lower levels of achievement over time is really unknown at this time. And then we have a little bit more data about what happens to these individuals once they leave the education platform. And what you see is that more than 50% of these individuals immediately after they leave high school are not participating in any kind of employment or education, which really differs from some other surveys or data looking at parental expectation for what the long-term outcome for these children is going to be. If you look out 6 years, what you see is that this gets a little bit better, somewhere in the 34% range of individuals have participated in some college, and about 55% are receiving some paid employment. That still means that about 45% of individuals are still not engaged in any formal employment past 6 years of graduation or receiving a high school certificate. So there's still a lot that's unknown about what occurs in this transition period. It's also really important to think about autonomy and consent and guardianship in the context of what's occurred with individuals with disabilities in the past. So what we know for individuals with disabilities is that there's a long history of discrimination, as well as what we would consider to be abusive practices in the past. So things such as forced sterilization, which is actually not that far in the recent past, as well as forced institutionalization. So I have stories of individuals or families who I see of patients who are now in their 50s and 60s, whose parents tell me that when they were born and first identified as having a developmental disability early in childhood, that those parents were very strongly encouraged to drop their children off in these institutions and give up their parental rights. And that was a really common strategy in the mid to early 1900s. The other issue that occurred and still continues to be a complex issue is the issue around educational opportunities that then leads to further economic opportunities. And so there's a long history of marginalization, both for education and for economic opportunities. So if we look at a timeline of what's occurred over time, and this kind of dates me because it shows how old I am. To me, when I think about 1975 and 1980, those feel like right within my time in which I was existing on this earth, right? So it wasn't until 1975 that there was a law passed where individuals with disabilities were guaranteed a free and appropriate education. So until then, that was not a guarantee. And it was in that same year that this very famous institution called Willowbrook State School was finally closed after the New York State governor signed into law closing down an institution that had been well established to be engaging in abusive and neglectful practice towards individuals with disabilities. And it wasn't until 1980 that a law was passed that individuals with disabilities could not be institutionalized against their will, which was fairly recent. So you would have individuals who were forcibly placed in these institutions and lived there for the remainder of their life. Moving forward, you can see that it wasn't until 1986 that the airline industry, a law was passed where they were unable to further discriminate against individuals with disabilities. And it wasn't until 1990 that we see the American with Disabilities Act becoming law, and you see what you see now in a number of different government and health system agencies where you're looking at accessibility for individuals with disabilities as well as opportunities. But I think looking at the past doesn't take away ongoing concerns currently. So some major concerns that I continue to hear about from the patients that I take care of fall within this framework. And this is where things get complicated because it becomes difficult to legislate issues like coercive relationships or social manipulation or abuse that occurs within caregiver agencies. So I actually recently took care of a patient who came to see me from Lansing after their long-term psychiatrist had actually died, and they were really struggling to find a psychiatrist in the state of Michigan to continue care for their now adult child. And they brought their son in to see me, who now I think was around 28 years old. And in the course of kind of going through his history and understanding some of the issues that he's dealt with over time, the parents spent much of their evaluation in tears because one thing that they spoke about with me is no one has ever asked them about the abuse that this nonverbal individual who was not mobile had experienced at the hands of caregivers in the school setting. So there were multiple caregivers in the school setting who had been convicted of sexual abuse and physical abuse and likely had engaged in physical and sexual abuse towards this individual. And now we're talking in the last 10 years, right? So when we think about that patient and his decline in functioning, much of it had been tied to events that had occurred over time that were likely tied to abuse by caregivers. And these were individuals that the parents trusted. You're dropping your child off to school and assuming that this is a safe and protected environment. So you kind of move forward into individuals who are verbal and able to engage in social relationships, and then you see another kind of complex layer of social dynamics. And so this is one in which individuals with developmental disabilities can be more vulnerable to manipulation from other individuals who are seeking to take advantage of them. So a nice, or not a nice example, but an example that I often think about or talk about when I'm teaching individuals about how to plan for individuals with disabilities throughout their lifetime is thinking about cell phone access, right? So I recently had a patient who obtained a cell phone as a teenager, which was developmentally appropriate for her. And what the parents later found out was that there were multiple individuals who she considered to be friends that she was going to school with who were asking her to give them money, which she was doing, but were also actively asking her to engage in sexual activities with her. And this question about whether or not she was engaging in these conversations in a consensual way was really complicated. So, she was a 15-year-old and she's having conversations with individuals who are also 15. But what does it mean for those individuals who recognize that she does not understand to the same degree what they're asking of her in the same ways that they do? And thinking about what it means for consent and autonomy in those relationships. And that, I think those are ongoing conversations that I've been having with this family over the last year or so in thinking about how do we provide her autonomy to engage socially with her peers, but do it in a way that protects her in the context of potential for abuse or manipulation from people who are her classmates. So these bring up a number of different complex issues around consent even for things as simple as, going over to someone's house to engage with a peer or engaging with someone over text message. So I wanted to kind of bring this back into thinking about the ethical framework that we use here in medical ethics, and thinking about autonomy and individuals' ability to make independent decisions, thinking about beneficence and non-malfeasance, what is in the best interest of this patient, how do we prevent harm to this patient, and thinking about what is just or fair or equitable. And this last piece about justice is something actually that I hear patients comment about a lot. So this is something that they're coming back and talking to me as their care provider, as well as to their parents about. So what does it mean when their sibling was able to obtain their driver's license at 16 and to be able to go to the grocery store, to go buy a bottle of pop? And what does it mean for them then to be restricted, and that idea of what is considered fair? And so there's a lot of these conversations around justice and fairness, which seem to me to come up actually even more often than this idea of autonomy, and a lot of thinking about really very complex thinking about how they place themselves in comparison with their peers. Achievement of life goals and milestones becomes a large part of our conversations, especially as they age into adulthood. So this idea that they would move out of the house and obtain their own place of living, that they're able to obtain employment, that they engage in romantic relationships. These are important, meaningful milestones for these individuals. And it's complicated as they traverse these conversations with their parents, who have been so used to engaging with them in such a highly structured way, where every interaction is structured and supervised, and moving them towards more autonomy in a way that feels fair to these individuals. But I think the piece that becomes really complicated is that it's really challenging to think about it without thinking about each child individually, each child or adult. There's a wide range of functioning that occurs that is not just tied to IQ. So there are many individuals who have intellectual functioning that falls within a normal range or a low normal range, who are actually functioning adaptively well below that and require significant supports. So I actually recently had a conversation about with another provider, as we were talking about how to figure out what would be in the best interest of this student here at the University of Michigan, who had been doing very well for a very long time. And then as they were kind of approaching moving into this next phase, was really struggling. And it came to light, actually, that this individual was receiving a significant amount of support from family members, even while they were living individually on their own in a college setting and functioning well academically. And so what did that mean for their ability to really kind of function independently going forward? And so we start thinking about these levels of support very early on, and thinking about beginning to introduce autonomy and decision-making early, so that we can gauge where it is that individuals need support as they move into adulthood. So this was a very interesting framework put forth by Lowton and Els, looking at individuals with more significant impairments, where there are concerns around power dynamics with caregivers, ability to engage autonomously, participation in decision-making, and how to empower individuals to express their interests and preference. One thing in working with individuals across the age spectrum and developmental disability spectrum is that you see over time that individuals are reinforced to be, to try to people please, to try to meet what it is that they non-verbally feel like that caregiver wants from them. And so they become much more hesitant to express their own preferences. And so how do you empower individuals to do that? And so they suggested using this overall framework of thinking about respect for persons as a way to think about engagement in decision making. So in this framework, you're thinking about autonomy, beneficence, justice, power, participation, empowerment, all kind of falling within this framework of how to respect an individual's wishes and preferences. And I thought that was an interesting way of thinking about it. And you'll see that as we kind of discuss some of these cases about how this becomes more complex. I also think it's really important for us to kind of look in more depth at where the American Association for Intellectual and Developmental Disabilities has landed on guardianship. And I think for me, this has been has had real life implications for my clinical practice, because it's been very interesting to watch families who do need to kind of move towards guardianship and the struggles that they've had in obtaining guardianship. And actually, I'm scheduled to go to Livingston County this Friday to help a family testify on behalf of an individual to help them obtain guardianship for their now adult child who has been denied guardianship several times and is now likely at the point where that is required. And what was interesting in talking to that family is that they discussed working with a number of disability groups over time and really kind of working along the framework of using guardianship as a last resort, which is generally a framework that we think about for these individuals with disabilities. So looking at some of the kind of larger tenets in this position statement. So the first of, and I think, I really think this position statement should be something that is required reading for many of us who engage with developmental disabilities. It really provides a very nice framework for something that came from the disability community themselves in thinking about decision-making capacity and development of decision-making, how they feel about guardianship, and how we should engage with individuals even when they already do have guardianship in place. So one is to presume with individuals with developmental disabilities, just as you would presume with individuals who do not have a disability, that they do have decision-making capacity. So you're coming from a framework that capacity is present. And that sounds straightforward, but you would be surprised how often parents tell me that when they come into the office to meet me, that often individuals actually never direct questions to the individual with a disability. That usually eye contact and nonverbal behaviors and all discussion around medical consent occurs solely with the parents, even though it's clear that the individual, child or adult, has the capacity to engage in the discussion and describe their preferences. So one good example of this that I was actually just discussing with Dr. Virkler is there's some nice cases that were published in JAMA looking at individuals with autism and decision-making capacity. And I was really kind of struck at one of the cases that had been published 2 years ago, talking about an individual who was 18, who came in with their parents, who expressed a preference for coming off their antipsychotic medication. And for me, that's a very clear situation. If you have an individual who has a high level of adaptive functioning, has been able to engage in multiple social, educational, employment-related structures, and they come in and they are able to engage with you around a risk-benefit discussion, when they clearly express their preferences, that decision feels clear. It was really interesting to me to see the framework of thinking in that case around how to think about limitations of consent in an individual like that, which made me really concerned about maybe the ongoing societal framework for not kind of taking on an individual's description of what their preferences are. So that's one. The second is preservation of legal capacity. So this idea that even as capacity becomes more challenging, or individuals are placed in circumstances where there's questions around capacity, the framework is based around trying to preserve capacity if possible. The third framework is to work towards developing decision-making from early on and to provide those supports throughout the course of someone's life so that they're able to engage in decision-making. And the last is not to interpret communication challenges as an inability to engage in shared decision-making. So to me, all of these seem very straightforward. But again, I feel like these are situations which often are not utilized to their full extent. They then provide further guidance on what should occur when an individual is in a situation in which they have been placed under guardianship of another individual. So what should it look like for engagement and participation in decision-making when that's already taken place? And they made a very interesting statement about, in this position statement, about why guardianship is a non-preferred action in individuals with disabilities, including the idea that it is stigmatizing, that you're removing an individual's autonomy for making decisions that they may be capable of engaging in, and that it becomes less clear about who that individual who maintains decision-making capacity is over time. And I'll discuss that in one of the cases and how that plays a role in someone's autonomy. So one thing that they suggest is to engage in less restrictive means of decision-making support. So whether that's power of attorney or healthcare proxies, and trying those and documenting that those have been attempted and failed before engaging in guardianship. And then secondly, for those individuals for whom guardianship has already been established, continuing to give them opportunities to engage to the maximum extent possible in making their own decisions, and then ensuring that their preferences and desires are known and achieved to the fullest extent possible. So even when someone's guardianship has been established, there still is this idea that they still would continue to participate, that that's an expectation, and that their preferences and desires are still made known and attempt to be achieved. So this first case that I want to discuss was of a case that brought forth a number of different issues regarding what to do around placement. So this was an individual who had both mild cognitive impairment and autism spectrum disorder, who had been in my care for several years as he was making the transition from adolescence to adulthood. As he transitioned into adulthood, he had been living with his parents during that period of time. And then an issue came up about thinking about placing him outside the home into an adult group home. During the course of the discussions that we had together, the parents were also considering obtaining guardianship. So all of these things were occurring simultaneously. The individual that we're talking about in this case was not fully able to engage in conversations around guardianship. However, he was able to engage in discussion around where he preferred to be placed. And it was very clear from early on that he preferred not to be placed outside the home. So he would come into the office and talk about, we would talk about whether or not he would be placed into a group home. And he would very clearly say that he wanted to stay with his father in his house, in his own room. And eventually the decision was made by his parents to place him into an adult group home. I think one of the things that was challenging for me then was thinking about what to do after that placement took place, which it was clear was not in this patient's preference. So after he came back into my office, it became very apparent that he likely was being neglected in that placement. So he would come wearing individuals' clothes that were not his, with his shirt not buttoned appropriately. It was clear that his teeth had not been brushed for several weeks. And then he was brought into the office really for the idea that he was kind of more agitated and aggressive. And so what were we going to do to think about managing agitation and aggression? And as I was kind of pointing these issues out to the parents, again, you hear the patient bringing up the fact that he does not want to live there, that he does not feel comfortable there. We were able to engage with him around thinking about whether he felt safe there, and it was clear that he did not feel safe there. And so for me, being in that space with that family, it was a very complicated conversation around what I would be willing to engage in for this patient around medication management in the context of what likely was related to neglect and possibly abuse. We did, because he is considered a vulnerable individual now, as an adult, you're able to file for adult protective services, and yet that often does not result in significant changes to that individual's placement. So it became clear over time that despite repeated attempts to move him from that placement, that likely was not going to happen. And so, again, it led to a difficult conversation with the parents around this patient's expressed preference, attempting to do no harm by this patient, by exposing him to other medications or having him being placed in an environment that was potentially unsafe for him, as well as working towards my relationship as a physician between the parents, as well as my relationship as a physician with the individual who was actually my patient. So this individual, kind of after repeated discussions around thinking about alternative placement options, was unfortunately eventually lost to follow-up. I think it became clear that what the parents were kind of willing to engage in around this child and what his needs were, and what I was suggesting maybe were not in congruence with each other, unfortunately. A second case, and I continue to care for this individual, is an individual who is currently in his 60s, whose parents are now approaching their 90s. And he's a very interesting individual who was able to graduate from high school, recently celebrated 35 years of supported employment, which was a huge celebration, and has been able to live independently with supports. So he's kind of moved into this framework of quality of life that we're hoping to achieve for many individuals who have both cognitive impairment and autism spectrum disorder. The place where this case became complicated was when he had his first kind of medical complication, was the development of kidney stones. So when he developed kidney stones, the parents had initially come to me with complaints that he had been increasingly aggressive and they weren't sure how to manage it. In conversations with him using an adaptive pain scale, it was clear that he was in pain. So we were able to kind of move him back to his primary care physician, at which time he was determined to have kidney stones. What then occurred next is, in the context of that evaluation, it became clear that he was struggling to consent for the procedure. And actually, during the course of that, because he did not have either a healthcare proxy or a power of attorney or a guardian, he was asked to consent for all of his procedures on his own because guardianship was not in place. And I had multiple conversations with the urologist, and we actually ran into a very unusual situation where the patient was actually signed the consent form. I can't remember what it was for, and it was scanned into the chart, and the family actually received a call back from HIM here asking if they had forged the individual's signature and that they would not accept the consent form. And then I had to have a conversation with HIM saying that, like, I watched him sign that form. He did it right in front of me. He's clearly capable of signing this form and engaging in consent for this medication that we were thinking about adding. However, in the course of that, the family also began to have health problems of their own, the parents. And so then this brought up an issue of whether or not to establish a guardian for him. And this was something that they had never considered before. And we really had a number of conversations about in terms of thinking about his ability to engage with autonomy in his own decision-making, which he's been able to do for the majority of his life. But the issue that came into play here is the parents were very concerned that if they did not establish who would kind of engage in his care after their own death, they were worried about who that would be passed on to. And so because they had been so intimately involved in his care and his life for so many decades, they were really concerned. And there is actually quite a lot of evidence that there are many situations in which individuals who are assigned as guardians actually also are given full financial control over individuals. And that actually is also included in the American Association for Intellectual and Developmental Disabilities position statement, that those two elements should be separated, that they shouldn't be tied together. And I think that's another important recommendation. And so they had significant concerns that all of their property and wealth was going to be passed on to their son, who may then be subject to manipulation or coercion by other individuals if they did not establish a clear delineation of responsibility for him beforehand. What was very interesting for him was that, again, he was an individual who, whatever you asked of him, he consented to. And that also made it very complicated. So when we had conversations with him about whether or not, how he felt about his own decision-making, what he thought about obtaining a guardian, it was clear that he was going to say yes to anything that we asked of him. And that raised another level of concern for us about thinking about whether or not to establish a guardian for him. I think ideally we would have chosen to not establish a guardian for him. He clearly has the ability to make his own decisions. He has the ability to participate in his own decisions. But given that he had the potential for manipulation, we were concerned about that and kind of moved forward towards guardianship. The next thing that actually took place that was very interesting was that they filed for guardianship and the family was actually denied. So the courts then decided that he was not eligible for guardianship. So then we brought back to the table what were going to be the other pieces that were going to be put in place to try to protect him from this potential. He was another individual, actually, who had a number of different caregivers in the home, And it became clear over time that those caregivers were removing the medications from his home and taking it for himself. Like when we were doing pill counts, it was really clear that they were being diverted. And it was very difficult to discuss with this patient because he saw those caregivers as his friends. And so when they asked him for a benzodiazepine or a pain medication, he gave it to them. And so he didn't see that as being anything that was problematic. And yet, it was clear that he wasn't receiving the medications that he was supposed to be receiving. And he wasn't, and I think this is a common theme that I continue to see with individuals with disabilities when caregivers are involved, that there's a lot of turnover that exists in these caregivers. One thing that these families have mentioned is that many of the caregivers are actually somehow, I have no idea how, but paid below minimum wage, and often don't have a requirement for a certain skill set to engage as a caregiver. And so many of them come in and display concerning behaviors. And so these parents have been very involved in any new caregiver that was coming into their house, doing their own level of screening, being involved in providing oversight. And they were worried that if that responsibility after they passed away was given to somebody else, what that would mean for their son. So this case is actually still ongoing, and we're still in the process of kind of figuring out what would be the best level or kind of most reasonable level of engagement and participation in balance with autonomy. And that's about it.